So hello, so we're returning now back for part 2 of our case of a fever in the gentleman and the patient we've discussed, and so we'll jump right in. As we recall, the case was that of a 42-year-old male. He presented to us with 2 weeks of fever, and we since obtained further history of abdominal pain, tachypnea, tachycardia, and hypotension. We noted also that the patient was quite confused. So we discussed in our initial actions, the patient was febrile, hypotensive, and ill-appearing. We obtained a rapid blood sugar. We obtained IV access, provided IV fluids, placed the patient on a cardiac monitor, and provided the patient with oxygen. We have then obtained further information with the sample history and a focused physical examination. That process really has a goal of identifying immediate life threats, and it's a very important part of the determination of the patient's differential diagnosis, because certainly we'd want to rank the components of the differential diagnosis that are acutely life-threatening and to address those first. Now, we did a little bit of that in the initial assessment when we assessed the patient's general condition and their ABCs. But of course, if we identified in our differential diagnosis, for instance, a very severe infection such as sepsis, we'd want to prioritize our thinking and our treatment of that particular diagnosis. So this is a brief list of things we should consider as immediate life threats relevant to this case. So first off, airway compromise. Does this patient have an expanding neck mass? Is there an abscess in the pharynx? Is there a lymph node that is potentially occluding the trachea? Does the patient have evidence of a central nervous system infection? In this case, possibly. The patient had a history of reported headache and altered mental status, certainly right now. Does the patient have sepsis? And sepsis is a very complex topic, and we will be hearing more about that. But essentially, does this patient have evidence of shock? And the answer is yes. The patient is hypotensive, has evidence of poor perfusion. They are confused, and they are tachycardic. Perhaps the patient, this is the point of addressing the patient's vital signs and determining if the patient has evidence of an infection. Does the patient have peritonitis? The patient does have abdominal pain. We'll hear more about this, but peritonitis certainly is a very serious infection. If we consider that in our differential diagnosis, we'd want to prioritize its treatment. Does the patient have severe respiratory infections? So in other words, is the patient hypoxic or have evidence of respiratory distress or respiratory failure? We certainly would want to approach this quickly. And then there's necrotizing skin or soft tissue infections. These infections can spread very, very fast and be very, very destructive. And as such, if we considered that this patient might have one of these infections, we would want to, of course, immediately intervene. All right, so based on that prioritizing, we would then want to develop a differential diagnosis for this patient. Thinking in general of fever, the differential diagnosis is quite extreme and quite long. And this is a brief, incomplete list of the potential, possibly dangerous diagnoses that we should consider in a patient presenting with fever. So of course, in this case, the patient is confused, had a history of headache, so very important to consider central nervous system possibilities, including meningitis, encephalitis, or brain abscess. And as I mentioned, there are quite a few other central nervous system infections that could contribute to this presentation. Does the patient have evidence of a pulmonary infection, something as straightforward as pneumonia, bronchitis, or perhaps an abscess? What potential cardiac diagnoses could contribute to this? In this case, the patient could have endocarditis or an infection of the heart valves. Is there evidence of myocarditis or pericarditis? What is the abdominal differential diagnosis like? Does this patient have a straightforward gastroenteritis? Is there evidence of a hepatic abscess, an abdominal abscess, perhaps typhoid, pancreatitis, or biliary problems such as cholecystitis or choledocholithiasis? Does this patient have any evidence of cutaneous infection such as cellulitis, an abscess, or perhaps fasciitis? The genitourinary considerations include cystitis, pyelonephritis or infection of the kidneys, or pelvic inflammatory disease. We must, as we discussed earlier, include sexually transmitted infections such as acute HIV infections. Secondary syphilis could also present in this manner, as would tuberovarian abscess related to chlamydia or gonorrhea in a female. The musculoskeletal examination could reveal septic arthritis or pyomyositis, an infection of the deep tissues or muscles. And then lastly, we'll want to consider other infectious processes such as malaria, as we discussed before, brucellosis, dengue fever, leptospirosis, yellow fever, influenza, viral illnesses, or tuberculosis. Tuberculosis on its own is quite a large topic and can present with multiple findings in multiple tissue beds. So it'll be very important to consider all of these when we are approaching a patient with undifferentiated fever. It is also important to consider non-infectious causes of fever, there are many. Whenever we think of fever, we automatically think of an infectious source, but certainly patients can have fever from non-infectious causes, such as a drug reaction, an allergic reaction to a particular medication. An autoimmune or rheumatologic factors could contribute. Does this patient have lupus or rheumatoid arthritis? Does this patient have rheumatic fever? Do they have a history of rheumatic fever or a history of streptococcal infection? Does the patient have thrombotic or embolic diagnoses? So does the patient have a deep venous thrombosis or a pulmonary embolus? Is the patient hyperthyroid? Do they have thyrotoxicosis, which can frequently present with fever? Does the patient have evidence of a malignancy? Or does the patient have evidence of failed chromocytoma, both of which could contribute to a fever in the absence of an infection? So at this point, we want to think about the information we've gathered from our initial assessment, our history, and our focused physical examination. We want to put the story together. So we have a 42-year-old male with 2 weeks of fever, recently returned from India. We've noted abdominal pain, tachypnea, tachycardia, and hypotension. We've also noted that they're confused. We've examined the patient and found they have diffuse abdominal tenderness and gross blood on the rectal exam. Another important historical point is that we've recently learned the patient was recently on a course of quinine to treat malaria. It does not seem like that has worked or resulted in an improvement in the patient's fever. So as we proceed, we get an update from the nurses that after the initial fluid bolus that we provided when we obtained IV access early in the patient's care, the patient's repeat vital signs have been obtained and the blood pressure is still low. It has improved somewhat and is now 88 over 44. The heart rate as well has improved a little bit, but it is still 110. So this is still evidence of potential shock, and the patient's blood pressure is low. We have to consider what intervention we should pursue at this point. We must remember the emergency medicine approach. When we get disturbing vital signs like this, it can be easy to kind of forget where we are and forget how to approach the patient. We must remember that after we complete the initial evaluation, changes in the patient condition or just persistent time passing should prompt us to reevaluate the patient and perform the same cycle again before we arrive at an ultimate disposition for the patient. So this reevaluation is what we can accomplish now, given that the patient has evidence of persistent poor vital signs. So this might include, in this case, further fluid bolus given the evidence of shock. As we continue to provide fluid resuscitation, we'd want to start to think about treatment. Now, we considered a moment ago some very dangerous potential differential diagnostic considerations, potential life threats. And this is where we would want to employ that list. As we've seen our patient with persistent poor vital signs, we've yet to obtain diagnostic studies or really narrow a differential diagnosis much. But we want to consider the things on that differential diagnosis that could really be dangerous and could respond better to early therapy. Many infections are worse when, of course, treatment is delayed, and we need to kind of consider which potential diagnoses could be possibly present and need to be treated acutely. Now, should this patient's shock persist, the low blood pressure tachycardia persist, at that point we'd also want to consider perhaps blood pressure support medications such as dopamine or norepinephrine or epinephrine. So, to touch on the point of empiric therapy again, I think this is very important. Patients who are critically ill may require early and aggressive therapy before the exact diagnosis is known. So this may require treatment for multiple different etiologies. So for instance, we may be covering a patient with antimicrobials for bacterial, viral, and fungal infections. But if the diagnosis is potentially severe, the patient's outcome is in question, and they are critically ill, we potentially have to do this to prevent delays in treatment that may result if we await for the return of diagnostic studies, which may return hours to days later. There are many infections as well which have clear benefit from early treatment. All right, so now as we've gotten to this point, we want to think about our diagnostic studies. We've developed a differential diagnosis, and in front of us here is a list of, certainly not an exhaustive list, but a list of common diagnostic studies that we obtain in the emergency room. So for instance, radiographic imaging, either x-rays or CAT scans of the brain, the abdominal space, as well as the chest. We could as well obtain cultures of the blood, of the urine. We could perform a lumbar puncture to obtain a CSF culture or an analysis to determine if there's presence of a meningitis. We could perform cardiac ultrasound to determine if the patient has evidence of cardiac valvular vegetations, as might be the case in the presence of endocarditis. We could obtain specific tests such as thick and thin smears for malaria or rapid tests for malaria and serology for illnesses such as typhoid. It's going to be also very important to obtain general studies, such as the complete blood count, a chemistry panel, biliary and liver function tests, stool studies, perhaps a coagulation panel, and then viral studies, including serology, a direct fluorescent antibody testing, or viral culture. And these will be directed by the patient's presentation, the ecology of the place where they traveled from, as well as the possible differential diagnostic considerations. So in this patient, we obtained a few different studies here. We obtained a chest x-ray because certainly this is a very common procedure that we obtain in patients, and their lack of respiratory findings on examination does not preclude the presence of serious chest findings. We also obtained blood cultures, a lumbar puncture for evidence of meningitis, urine cultures, and we also sent malaria testing as well as typhoid testing. Complete blood count, chemistry panel, and biliary and liver function tests were also sent. All right, so we'll get some of this information back fairly quickly, and as is the case, we typically get some of these labs back. The complete blood count is normal. The white blood cell count is normal. The hemoglobin and hematocrit are normal as well. Electrolytes such as sodium, potassium are normal, as is kidney function tests. The liver function tests are normal, and blood and urine cultures at this point are normal and have not returned. These tests, of course, take several days to return. We obtained the lumbar puncture and a CSF culture. The lumbar puncture is normal, showing no evidence of meningitis, and the culture is pending. The malaria smear is pending as well. So this is our chest film, and this is a very important study to get in this patient. They did have abdominal pain, and we have not performed any abdominal imaging, but in this x-ray we can see a very clear indicator of intra-abdominal pathology. And that will be important to see here. As we recall from the lecture on chest x-ray interpretation, you can see if you look at the right hemidiaphragm, this subtle dark crescent there, which may be reflective of air under the diaphragm. And that in turn may be indicative of a perforated abdominal viscus or a perforated intestine. And that's going to be a very important finding, crucial finding, in fact, because missing this diagnosis could have very, very severe outcomes for the patient. A perforated viscus is a very serious diagnosis. So, summary thus far, we developed a differential diagnosis. We evaluated differential diagnosis for potential threats to life acutely that we'd want to prioritize and think about treating. We reevaluated our patient given that the persistence of their poor performance and vital signs. We obtained diagnostic studies broadly in this patient to determine what the diagnosis was, and we considered empiric therapy, or therapy for covering potentially serious infectious potentially serious causes of the patient's fever without actually having much of our diagnostic studies return. And then we now considering the actual diagnosis on our patient. So this concludes part 2. In a moment, we'll discuss part 3 and the actual diagnosis and treatment of this patient.